and so mixed method impact evaluations, but I won't be talking about that today because time won't allow it. But I would strongly encourage you to always think about using mixed method designs. So I'm going to share my screen now. And if you can't see it, please shout out. It is quite a long presentation. I will try to not get too fast at any point. And there we go. All right, so you're there in Ubuntu attending an evaluation boot camp, and I looked at the expectations of what your expectations for the course that Ms. Chimke sent round. And so I understand many of you come from a monitoring and evaluation background. And so there's two different meanings of the word impact in the evaluation community. And the conflating of those two has led to a lot of debate. There's something called the evaluation wars. And the evaluation wars are about people who say that randomized control trials should not be used, they're not appropriate, they're very limited validity and so on. And those, which would include me, who promote randomized control trials. And these evaluation wars are not unique to international development. They take place in every single sector of social policy. But particularly in the development space, where you have this terminology that's very commonly used related to what was the log frame and is now used in the context of theories of change, is that you have this chain of indicators. So you have inputs being provided, and those inputs are used to finance activities. Those activities produce outputs like buildings built, roads constructed, people trained, and so on. And then that achieves two outcomes, which might be intermediate outcomes and final outcomes. And then you have impact. And in this traditional meaning of the word impact, it refers actually to, again, two things which are related. One is long-run effects. So in the OECD DAC definition of impact, it used to exclusively mean long-run effects. They've changed that now in 3-4 years ago, but it used to exclusively mean long-run effects. And the other meaning is higher order welfare effects. So the effect on poverty or empowerment or maybe employment, but certainly any sort of high-level well-being measure. And so having a child enrolled in school, or maybe even better learning outcomes, would be an outcome, but the higher income and the move out of poverty that results from better education would be an impact. So this higher order welfare effects also referred to impact. That's one meaning of impact, and that's the common meaning in the M&E community. And I don't use the word impact myself in that context because it's confusing, given the other meaning of the word impact. The other meaning of the word impact is in impact evaluation. And so impact evaluation specifically means what difference the intervention made. That's a type of evaluation. It's well recognized. There's a thesaurus of evaluation done by Michael Scriven, published first in the late 60s, I think. And Scriven had a typology evaluation back from the 60s, where he distinguished process and impact evaluations clearly. And he puts it very nicely that in impact evaluations, you're interested in the outcomes that were achieved by the intervention. And in a process evaluation, the evaluand, the thing you're evaluating, is not the outcomes, but the intervention itself. That's the key difference between process evaluation and impact evaluation. So in impact evaluation, you're interested in the outcomes that were achieved, and you're interested in those outcomes that were achieved compared to what would have been achieved in the absence of the intervention. Impact evaluation is necessarily a counterfactual analysis what happened with the intervention compared to what would have happened in the absence of intervention. Now, the confusion happens because agencies, and I'm thinking of agencies like the European Commission in particular, because they're still in this place, haven't moved in the last 20 years, the agencies will do an evaluation using the term impact in the first meaning of the word, and then say, oh, because it looks at impact, it's an impact evaluation. But it's not. Because it's got to have a counterfactual analysis to count as an impact evaluation. That counterfactual analysis might be large N or small n, which I'll explain in a moment. Doesn't have to be an RCT at all. It can be, but doesn't have to be an impact evaluation. But it has to make a counterfactual analysis of what happened with the intervention compared to what would have happened in the absence of the intervention. That's what the word impact means in the term impact evaluation. So here it is a statement again. So in other words, how did the state of the world change? It's a very general definition. How did the state of the world change as a result of the intervention? And so they're making causal claims. The intervention, I refer to 4Ps. The intervention might be a policy, it might be a program, it might be a project, it might be a practice. So I call these the 4Ps. Impact evaluation can be used to apply to any of those policies, programs, projects, or practices. And impact evaluations make causal claims about what happens as a result of that intervention, that policy or program or project or practice. So we can distinguish large N impact evaluations. The N refers to sample size. So if you're doing intervention that covers lots of communities, lots of firms, lots of schools, whatever, lots of women's groups, doing intervention that covers a large number of people, then you can do a large N impact evaluation. And that includes experimental designs, which are primarily mostly randomized controlled trials. They're also natural experiments, but they're very rare. And non-experimental designs, which are mostly a form of matching. They're not all matching, but experimental designs are mostly some form of matching. And then you've got small N impact evaluations, like contribution analysis, which is one of the earliest forms of small N impact evaluation. And these are all based around a theory of change approach. So well, how is it we expect this intervention to cause this change in outcomes? Let's look at whether this theory operates in practice. I'll say a little bit about small n. Now, other terms you'll hear used and in ways that I strongly disagree with. I have a paper published in 2009, I think it was, called Some Contributions to Current Debates and Impact Evaluation, where I discuss the point about the different means of impact and this point about contribution versus attribution in more detail. So that paper was published in the journal Evaluation. And so a lot of people say, oh, well, we've got a complex intervention, another term I hate. And so we can't talk about attribution, we only talk about contribution. Now, I don't like complex intervention as a term because it's something people just hide behind. They say, oh, it's very complex, you can't analyze it. Nonsense. Okay. All social interventions are complex. The design implementation will vary place to place, the target population varies. All this makes it complex. RCT is actually very good at evaluating complex interventions because they just look at, well, we did this, and that was the outcome here compared to the comparison group. So complexity is no challenge for RCTs at all. So the statement that RCTs can't handle complexity is just wrong. But also the statement that RCTs do attribution, not contribution, is also wrong. And when people say RCTs only look at attribution, they have in mind actually three things, and I've got two listed here. One is that they talk about sole attribution. So, oh, we did this intervention, that was the reason, and that was the only reason why this outcome was observed, this change outcome was observed. That is simply not true. The outcome changes in the control group as well. That's why we have a control group. We don't think the whole observed change in the outcome is because of the intervention. That's why we're doing an impact evaluation with a comparison group, because we think, oh, that outcome's going to change anyway. How much of that change can be attributed to the intervention, which is, in my mind, the same as contribution. It made a contribution to the overall share of the change in the outcome. So I don't see the difference between attribution and contribution there. We're never claiming that the whole of the change is because of the intervention. We're saying this much of the change was because of the intervention. I did it. One of my studies at the World Bank was on primary education, basic education in Ghana, and there'd been a 12% increase in enrollments over the 15 years I was looking at. And I said, well, a third of that, 4% of that change is because of World Bank supported investments in books and buildings in basic education. So I'm saying, okay, there's a 12% change. The World Bank support contributed a third of that by doing this regression-based analysis in that study. The second thing about attribution is they're claiming a deterministic relationship. Oh, if you do this intervention, you'll necessarily get this outcome. That is simply untrue again. So large N impact evaluations make probabilistic statements, not deterministic ones. They say, okay, if a young person is exposed to this intervention, there's a 10% increase in the probability they'll go into a job. If a family has access to clean water, there's a 60% reduction in the chance that a child will get diarrhea over a 1 month period or 2 month period. And so you're making probabilistic statements about reduction in bad events happening. All interventions have a probabilistic effect on outcomes. There's no certainty. So we used to say there's no vaccine against poverty. There's no vaccine for girls' empowerment. But actually, because of COVID, we all now know that vaccines don't work 100% either. We did know that before, but now everyone knows that. And so there's no vaccine for vaccines either. There's nothing that works with certainty. And the other thing I've not mentioned here, I discussed more on the paper I mentioned, is about linearity. And so there's a claim that RCTs assume a linear relationship. Again, nonsense. I won't go into that in any detail, but amongst people on the other side, to me, in the evaluation wars, the word linear is a dirty word. Just if you just call something linear, that's like a way of discrediting it. It's something I don't understand why saying something linear should discrediting it. And they don't even what they mean by linear is not clear. They often mean unidirectional, not linear. But strictly linear means you've got a straight line relationship rather than a curved relationship. Relationship between, say, life expectancy or literacy or infant mortality and income per capita is convex. So it's a log linear relationship, not a linear relationship. But that's not what they mean generally. There can be breaks in the relationship. There can be non-linear relationships. There can be feedback loops, bidirectional causality. All of these can be taken care of in large N designs. Okay, so in fact, selection bias, the main reason we do large N impact designs, is an example of bidirectional causality. So it's again nonsense to say that large N studies can't handle this and RCTs can't handle these problems. What is important to do or useful to do, and is not usually done, is distinguish the nature of the causal claim being made by the different impact evaluation designs, by large N and small n. So the causal claim, and this word claim is an important one, it's underused in the literature. So evaluators make evidence claims. They've looked at the evidence and make an evidence claim. So we'll say any statement that's empirically based is an evidence claim. So you could say the people in the community valued this intervention, the project, and thought it was very useful. It's fairly useless finding, I would say, to that one, to be honest. There's lots of biases in a questionnaire that asks a question like, did you think the product was useful? So I wouldn't go down that route, but that is an evidence claim. Okay, so it's a factual evidence claim, not a counterfactual one. And something more useful would be, for example, of the people reached by this project, 60% were in the intended target group. So the project reached 1,000 people, 600 were in the intended target group, 400 were not in the intended target group. Would be a fairly good number. Normally you get numbers in the target group being around 30–40% of participants. And of those in the target group, only 20% were reached in the project areas, who had 2,000 target people in target group project areas, and 400 of those were reached, so 20%. They're factual statements, they're evidence claims. They're not causal claims. Causal claims are doing X, this intervention, caused Y, a change in the outcomes to happen. If you're saying doing X means Y will definitely happen, like if I pick up this cushion, you can't say cushion and let it go, it drops to the ground. Okay, I'm not living in a vacuum, so I'm sure that's going to happen. That's a deterministic statement. Okay, so I know that's going to happen. But impact evaluators, I already said, they make causal claims, but they're not deterministic causal claims. They're not saying you do this will definitely happen. It's saying you do this, there's an increased probability this outcome will be observed in this group. So it's like also a prevalence statement. So in the treatment group before the intervention, 50% are poor. After the intervention, 40% will be poor. So a 10% absolute reduction in poverty or a 20% relative reduction in poverty is achieved by the intervention. So it's not that everyone exposed to intervention becomes not poor. There's no vaccine for poverty, but there's a reduction in the probability of being poor. So in the group as a whole, it's gone down from 50% from 40%. So the probability of any household, any one household in that intervention group being poor was 0.5, now it's 0.4. So it's a reduction in probability of being poor or people living in the program areas that were exposed to the program. So it's a causal claim, but a probabilistic causal claim. And so that's what large N quantitative approaches like RCTs do. Small n qualitative, small n approaches like process tracing, they don't make causal claims about probabilistic statements. They don't use numbers. They can't. They can't make a quantified causal claim, but they make a different type of causal claim about necessary and sufficient conditions. So they say, okay, if we're doing some work on peace building at the moment, which has been talking about this morning, so it's in my mind, having consensus from the various parts involved in a conflict or civil unrest in a particular country, having the consensus of those parties that the peacekeeping operation take place is a necessary condition or likely necessary condition that the peacekeeping operation will succeed. Having adequately trained, a sufficient number of adequately trained and disciplined troops, peacekeeping troops, which are both troops and police force, people going peacekeeping operations, policemen and women going peacekeeping operations, but they're adequately trained and have a clear mandate, which is well understood by all parties, is another probable necessary condition for the peacekeeping operations to succeed. So we're making statements about, well, what are necessary conditions? Are these sufficient conditions? It's very hard to have any condition that's sufficient. I mean, if you just do this, do that one thing, then you're going to achieve a successful peacekeeping operation. What you might have are combinations of necessary conditions that are individually not sufficient, but become sufficient when you've got a combination. So if you have consent, well-disciplined forces, clear mandate that's well understood and accepted, and you have the combination of those three things, maybe, I doubt it to be honest, maybe those three things are sufficient for success. I think it would nearly always be the case, peacekeeping operations, it will always be the case, some of the conditions for success are external to the intervention. And so they're outside your control. And so you might do everything right and the thing will still fail because part of the set of conditions that are necessary and sufficient are beyond your control. And so, but that's what small n evaluation should be evaluating and be clear when an operation failed, that was our fault. We had insufficient troops, the troops didn't act on their mandate, whatever, or we did everything right. It just the conditions weren't there for this operation to succeed. And the evaluation will talk about these necessary conditions. But small and impact evaluations actually rarely do that. They rarely use this terminology. And there are a lot of potential biases in these approaches. I'll come back to in a second. So there's more attention to these approaches. Conflict analysis has been around for some time. Its founder, John Main, just died fairly recently. Process tracing has become one of the more popular approaches, one of the most rigorous. It's been conceptually very analyzed. I wrote a paper on small n impact evaluation 10 years ago, and then we've done some work recently on small n impact evaluation for the Dutch Ministry of Foreign Affairs. There's been a very big evolution in these approaches over the last 10 years, and particularly with respect to two of them, process tracing, which has been much more developed conceptually, and outcome harvesting, which has become very popular. It's not very good. I'm not going to go into details why, but really outcome harvesting is the preferred approach. It's easy to do, it's cheap, but it's not very conceptually demanding, but it's not very good. So I don't recommend it. The common elements are having a theory of change, collecting data along the causal chain, and making plausible claims. So, okay, we're doing a training course like this one. So the first training course like this one, if one or two people attending the course do something different as a result of the course, that's a good success rate. I've done a lot of workshops of 30, 40 people, and if one or two people do something different as a result of that workshop, to me, that's a good success rate. Okay, it's like I'm affecting 5% of participants. That's a normal effect size. If you affect 5 to 10 5-10% of people taking part in intervention, significant way, that's the sort of effect we see in most interventions. So people have to turn up at the boot camp. They have to actually attend my session to learn anything from me. They have to stay awake in my session. And after lunch, it's really hard to get people to stay awake. They have to pay attention. They have to actually understand what I'm saying. have an English accent people find hard to understand. They have to um, they have to agree with what I'm saying. So part of the not process of actually absorbing and learning materials, you agree with it. If I've annoyed you in the first few minutes by saying, "Oh, the evaluation was," and people on the other side are wrong, then you've just tuned out. So you're not listening to anything else I say because I've undermined my credibility in your eyes. So the whole rest of the thing is a waste of time. So you've got to go along with what I'm saying, and then you've got to understand it, and then you've got to you learn what you're meant to do. Everyone's an A student. Most people don't get everything they're taught, and then you've got to actually go and do something about it. You've got to change your behaviour as a result of the training, not just mine, but the other training received at bootcamp, and then your outcomes in terms of what you do in your work and therefore your organizational performance ought to improve. And in the end, the higher level outcome, what's called the impact in the M&E terminology, is that the organization actually improves lives. And in the end, why we're doing this is to improve lives. And I believe in impact evaluation very strongly because it tells us what works and what doesn't work. And most things don't work. Okay. I said before, effect sizes like an effect size of training, that's the impact of training is very small, but actually most things don't work. 80% of things don't work. And so most things that the organisations are doing to reduce poverty, empower girls and women, to stop gender-based violence, to reduce infant mortality, and so on, most of those things don't work. And 80% don't work. And they don't know they don't work because they don't evaluate it properly. So impact evaluation is really, really important. Temporal consistency. So if Y is going, X is going to cause Y, X has to be done before Y, unless you make a claim expectation effects, but they're hard to demonstrate, but normally X has to go before Y, and you rule out other explanations. This is really badly done. So I have this cartoon here of these people lifting this stone, and the person at the end is saying, look at me lifting this rock all by myself. Okay, that might seem absurd, but that's exactly what evaluations do. So I'll give just one example, but it's just one I happen to know because I worked on the annual review of World Bank performance 3 or 4 years ago, and it's one of the studies we looked at during that review. And so it was a country evaluation for the Philippines. And in the Philippines, they introduced something called the sin tax. And the sin tax is a tax on tobacco and alcohol. And the money from that tax was going to be used to subsidize PhilHealth, the National Health Insurance Scheme. And in the country evaluation done by the World Bank of World Bank operations, it said, oh, the World Bank gave technical support to the government to introduce the sin tax, and this support was very valued by the government. And they don't mention anyone else being involved. So it makes it sound like, oh, this was the World Bank's idea, the World Bank supported the government, and the government did this because of the World Bank's technical assistance. Nothing could be further from true. So Harvard Business School done a case study of this reform, and it was a locally led initiative. There was a surgeon appointed Minister of Health who was strongly in favour of preventive health. And you had a president who himself was fully behind this. So it's a presidential level initiative. And the Treasury Minister was also behind the initiative and the idea of hypothecating the revenue from this tax into the health insurance scheme. So it's strongly nationally owned initiative. And a foundation called the Asia Foundation commissioned a local research body to do the formative research necessary in order to design the policy. And around 10 other organizations also did some research, including the World Bank. So in the Harvard case study, there is a line that says other supporting research was done by, and the list of organizations of which the World Bank is one. So I've got this people picking this stone up here. The analogy I usually use is pushing a car, but I couldn't draw a car very well, so I used the stone. The pushing the car analogy is that one person can't push a car, two can maybe push it, but three people can push a car easily. So three people are pushing a car. Who's pushing the car? So this is back to necessary and sufficient conditions. So collectively, they are necessary and sufficient, those three people. But any one person is not sufficient. But in the case of the Philippine syntax, the World Bank is like the seventh person pushing the car. They could have not pushed the car at all. It wouldn't have made any difference. So they're in picking the stone up here. The guy in the middle could have not moved away and they'd still be holding the stone. The World Bank's one of those people that could have stepped aside and the stone would still be held up. So this is common in small and impact evaluations. They don't look at what other actors are doing. as well. It's me, ignoring the role of others. Back to what is impact evaluation. I've had this slide. I thought I deleted it. So, okay. I've got a second definition here now, which is more specific. So it's the indicator, normally an outcome level indicator, with the intervention compared to what it would have been in the absence of the intervention. And we can write that algebraically. So Y is the outcome, T is time t, which is a time after the intervention occurred or at some point into the intervention, 6 months, 12 months, whatever. Depends on your temporal theory of change as to how long it will take the outcome to be achieved, which might be a matter of weeks or months. It could even be hours on some interventions, but it might also be years. And so people often ask me, when you do an impact evaluation, the answer is when there's been sufficient time for the impact to be observed, the outcome to be observed on a sufficient scale to do an impact evaluation. Excuse me. The 1 and the 0 refer to exposure to the intervention, so taking part in the policy, program, project, whatever. And so the 1 means this is a measurement of the outcome at time t for these people being exposed to the intervention. The naught means they weren't exposed to intervention. Same people, same point in time. What's their outcome if they weren't exposed to intervention? So here's the impact evaluation problem. You can see this. You can go along and say, okay, I've got a measure of girls' empowerment. I can measure girls' empowerment in this group of girls exposed to the program after the program. I've got that. What I don't know is what would their level of empowerment be at this point in time for those same girls had they not been exposed to the intervention. You can't observe that because they have been exposed to the intervention. So what we used is a comparison group that should be identical in all respects, except they weren't exposed to the intervention. And I can't see that. So random assignment is a very good way to get a comparison group. You randomly assign over a sufficient number of units, whether it's people, firms, schools, communities, whatever, randomly assign over a sufficient number of them by the law of large numbers, the average characteristics of those two groups will be the same. So outcome monitoring is not the same as impact evaluation. The 0 there did not refer to a point in time. The T refers to a point in time. It's the same point in time. Outcome monitoring looks at the change in the outcome over time, before and after the intervention. Now, there's been a huge rise in the results agenda in the last 20 years. And I had a blog recently, I called it the scourge of the results framework. Results reporting has been extremely damaging. It's an extremely bad thing. If you're an M&E officer, you probably spend a lot of your time doing so-called results reporting, where you're asked to collect higher level outcomes for the projects which are being carried out by your agency. It's a complete waste of time. There's no value whatsoever in doing that. I mean, you might want to know, it might be a bit interesting, but it tells you nothing whatsoever about the effect of your intervention. Here's an example. This one of the evaluations I did when I was at the World Bank of a nutrition program in Bangladesh. And the key logic of this program was we're going to give nutritional counseling to young mothers to change their nutritional practice for their babies, because the key cause of malnutrition in this area is bad feeding practices by young mothers. And so we're going to give them nutritional counselling, and that will improve feeding practices and therefore child nutritional outcomes. I have a whole presentation around this project. I don't have time for that now. Come to our impact. We're doing an impact evaluation course in Lanzhou, so just over the border, not far, for you in Lanzhou in November. Speak to Li Ping or Nina, who are there at the course with you in Bator, and they can tell you more about the course. A 3-week course we're doing, intensive course over 3 weeks, every day for 6 days a week. We'll be doing lectures. You'll hear a lot more about this project. So during this project, which started in the mid-90s, and I did the evaluation in 2004, or 2004, 2005, you've seen this reduction in malnutrition, particularly severe malnutrition, had reduced dramatically in project areas. And based on these monitoring data, the project staff were saying, oh, it's a great success, this project. It was a pilot project, and persuaded the president of the World Bank at the time, Wolfenson, to give an additional $1 billion. $1 billion, a lot of money we're talking about, additional $1 billion credit to the government of Bangladesh to scale up this project. We were doing a study of maternal and child health in Bangladesh at this time, and by and large, Bangladesh is certainly at the time an unrecognised success story. The success of Bangladesh is now more widely acknowledged. When I wrote this report, it was not widely known at all. Bangladesh is a huge success story in human development of its time, and human development is a precondition, is a necessary condition, and the data bear this out. Human capital development is a precondition for sustained economic growth. You can't invest in growth and then do human development. You have to do it the other way around. That's what Bangladesh did. It's now enjoying high rates of growth as a result. So generally a huge success story, but not this project. So we did an impact evaluation. I can't explain this graph. I don't have time. But basically we found a small and most likely insignificant effect of the project on anthropometric outcomes. That's height for age and weight for age of young children. And we had a theory of change to explain why that was. But I don't have time to go into that here. Come in November. But if you look at demographic and health survey data for all rural areas, it's a rural project. And so the solid lines are the project areas and the dotted lines are all rural areas. The project was just in 79 of Brazilians out of well over 1,000. So it's just in certain areas. You see actually malnutrition fell faster in non-project areas than in project areas. So this decline in malnutrition was not a project effect. It was not specific to project areas. The most likely explanation was the Green Revolution in Bangladesh. So back in the 80s, late 80s, with World Bank support, there had been a lot of investment in irrigation infrastructure. That led to investments in paddy and rice production. Irrigated rice production has a yield of around 4 to 5 hectares per acre compared to 2 hectares per acre for rain-fed paddy production. So huge increases in yield. And so the calorific availability of food just that went up by 1,000 calories per person over this period. It's an enormous increase from 2,500 to 3,500 calories per person roughly. And the price of rice fell and real incomes were growing. And so you've got a clear explanation for why severe malnutrition was more or less eliminated was based on increased food availability to households. It sends entitlement theory in a positive way when entitlements were growing. Coming on to what impact evaluation now, paint some more detail. So we've got to compare like with like. That's the problem. So I said, okay, you can't compare the outcomes for the people who got the intervention with the outcomes for the same people had they not got the intervention, because they did. We need to make a comparison group of similar people. And it must be identical. When we say identical, we don't mean like they all look the same or anything. We mean that the average characteristics must be the same. Same average age, same average education, same proportion of men and women, same proportion in rural areas, same average wealth and income, same average health status. So they have the same average characteristics. And having those average characteristics at baseline before the intervention, that's called baseline balance. So whenever you're doing the impact evaluation, it's really good to illustrate baseline balance. In other words, the characteristics of these two groups are the same before the intervention. As I said already, if you randomize over a sufficient number of units, you will get baseline balance. Just by chance, you won't get it sometimes, but if the sample is large enough, you should get baseline balance through random assignment of the intervention. The problem that we face if you're not doing random assignment is selection bias. And so normally when you have an intervention, those that take part are not like everybody else. There's either deliberate selection, we're targeting poor people, we're targeting people at risk of obesity, we're targeting young people who are unemployed, we're targeting young people at risk of offending, we're targeting people who are abusing substances. We've got a target group who are not like the rest of the population. So your comparison group just can't come from the general population. They've got to be a similar group. So either we target or there's self-selection. If you do a public works program where you're going to build a road but pay a minimum wage, that's self-targeting, because only people who are willing to work for minimum wage, who are the poor, will come and take part in that program. Those that already paid more minimum wage won't go and or have jobs paying minimum wage, won't go and do that project. What are called fair price shops, which are common in India, and actually here in Egypt where I am now, they sell subsidized commodities rice, bread, oil, and so on. Basic commodities at subsidised price, and they're put in poor areas. And normally, when a batch of commodities comes in, you have to queue to get the goods. So the idea is that better off people won't go to the poor areas to get the goods. Not entirely true, but also they won't queue up. When South Africa introduced a basic pension, and it wasn't targeted. Part of the idea was, yeah, but you have to go to the post office and queue up an hour or two to get it. And it's not for people who are well off, it's just not worth their time. They won't do it. But the poor clearly will do it. And so you can self-target in this way. So here's some examples of selection bias. So we have a productivity enhancement intervention in agriculture. It could be for livestock, of course, in the Mongolian setting, and it's targeted at poor marginal farmers or poor marginal herders. And so targeting those poor marginal farmers, they have less land, less assets, less likely to be literate, less labour, and so their outcomes and their productivity will be lower than that of other farmers on average. So if you've just compared the outcomes to farmers in the project to the outcomes of other farmers, you might find that farmers in the project have lower productivity than non-project farmers. You probably will find that. It's not because the project's not working, it's because you targeted low productivity farmers in the project. So to find out the effect of that project, you've got to compare the change in outcomes for the low productivity farmers in the project with similar low productivity marginal farmers who didn't take part in the project. You've got to compare like with like. Second example comes from self-selection. So farmer field schools are a very common form of farmer extension. They've become very popular in the last 20 years or so. And um, the way the project works, they go into community and they might use existing farmer groups, which already a form of self-selection and a bias, or they might ask farmers to volunteer to take part in the program, and then they form groups of those farmers. It's a group-based experiential learning intervention where farmers have pilot test plots where they try out different innovations they think are appropriate in their setting, and with advice from the extension worker, and compare those to their usual plots. So that's not the experiment we're interested in. The experiment interested in is the farmer field school itself. People self-select into the intervention. Farmers self-select. Which farmers like to self-select? It's those that are most interested in adopting new innovative approaches. So those farmers may well have adopted new innovative approaches even in the absence of intervention, because that's what they're interested in. So they found other ways to innovate. They would have spoken to the seed merchant. They would have gone to the agricultural office in town. They'd have done something else to try and innovate if the farm field school hadn't been there. And so we're not, if you compare those farmers with other farmers who didn't take part in the program, you're not comparing like with like. You've got to compare like with like. So an example of selection bias, we're back in Bangladesh. Here is the mortality rate. I think it's the neonatal mortality rate, which is the first month of life. For it might be infant, which is first year. Um, for children born in hospital, it's the first figure, 11.5%, to children born at home, which bulk of children, 90% born at home, deliveries in Bangladesh, where 6.5%, just over. So the fatality rate from home deliveries is half of that from hospital deliveries. So that makes it sound like, oh, being born in hospital is a really bad idea. It's a very high risk thing to do. I'd have my baby at home. We're not comparing like with like. As I said, 80% of our deliveries are home deliveries, so only 20% are going to hospital. Which 20% go to hospital? It's not the normal deliveries that going ahead just fine. It's deliveries identified by a health worker as being high risk prior to delivery, or they experience birth complications during the birth itself, and they're packed off in a truck or a van or a cart to go to the health clinic or hospital to deliver because it's too complicated for the traditional birth attendant to deal with. They're high risk pregnancies, complicated deliveries, and the death rate from those is much higher than the death rate from normal deliveries. So we're not comparing like with like because most of the home births are normal deliveries. And so what we want to know is what's the death rate from home deliveries with complications. And it's going to be higher than 6.7% and almost certainly higher than 7.5% as well. We're not comparing like with like. The second one is secondary education teenage pregnancy. So the study that found that girls who had experienced a pregnancy prior to the age of 18 were less likely to be in secondary school. So the argument is oh, that the argument made in the paper is that secondary education has a preventive effect. If you can keep girls in secondary education, that'll stop them being pregnant. But there's reverse causation here because the major reason for girls to out of school is getting pregnant. So you've got maybe staying in school reduce the chance of getting pregnant because you're investing more in human capital, you've got better prospects, you want to go and get a job and work and earn for some time before having childbearing responsibilities. So you're more careful, maybe you're better educated and better informed about safe sex and so on. But also, but it works the other way around as well. If a girl does get pregnant, she drops out of school. So you've got the reverse causation. And this is an example of what I meant when RCT can actually cut through this complexity. So I worked on this issue when I was doing my work study in Bangladesh. And it is really hard to solve the selection bias problem here to try and work out the protective effect of female secondary education. We 3i refinanced a study in Ghana which paid for school fees on a randomized control trial for girls to attend secondary school, and that study showed the protective effect of secondary education. So an RCT can cut through this bidirectional causality issue and actually make a causal claim about the protective effects of secondary education. And it's very hard to find a non-experimental design that can do that. So impact evaluation is to overcome the selection bias by random assignment, so randomly assigned intervention, like the Ghana case I just gave, using matching, or use what's called a valid instrument. Instrumental variables are the most complicated form of impact evaluation, and it's very, very, very hard to find a valid instrument. There are lots of cases, like a famous paper by Sister Flo and one this was second author is on dams in India. It's used instrumental variable approach. There's no way it's a valid instrument. So randomization, you're randomly assigning the treatment, and the unit of assignment might not be the same as the unit of treatment or the unit of analysis. And so you could randomize across villages, but look at individual learning outcomes, or randomize across schools, look at individual learning outcomes. Randomize across sub-district, measure village level outcomes. So in the example in that picture, which I'm going to go into in a bit more detail in a moment, this was an eyeglass experiment which has been done by a group called REAP, Rural Education Action Project, which is a collaboration between Stanford University and several Chinese universities. And 3i funded many of REAP's studies in the early days. And so the eyeglass experiment, the first one was done in Gansu province, where Lanzhou is. And it was randomized at the township level, and then all primary school aged children were tested in certain grades, I think grades 1 and 4, were tested, had their vision tested, and if they needed eyeglasses, they were given eyeglasses. And so it's randomized at township level, but the intervention is done at child level, and the outcome vision is learning outcomes. And there's a huge impact on learning outcomes from giving children needing them glasses, because the theory of change is very simple. They can't see the board, now they can see the board, therefore they learn more. So an example of an randomized controlled trial. Oh, the one above, another one that another REAP project. So anemia is a really big problem globally, particularly for girls. In rural areas in China, anemia rates are 50% or more, and anemia leads to cognitive deficiency. So if you have anemia, you just grow up less smart. And when you've got cognitive deficiency in childhood, it's irreversible. Nothing you can do about the cognitive deficiency from childhood that made you grow up less smart. So if you can correct this anemia, you can actually improve children's learning outcomes. And so what this intervention did was, again, it was 60 schools, 30 in the treatment group, 30 in the control group, and they gave a vitamin pill that contained iron. So iron is the key thing you're looking at when looking at anemia. Gave iron to the children on a daily basis, and again, a huge improvement in doing this intervention over a 6-month period led to actually a 6-month improvement in learning outcomes. So like a half-year additional learning is a 0.2 standard deviation effect size as a result of doing the intervention. So a huge impact on child learning, very, very cheap intervention, being quite widely adopted now in several provinces in China and tested elsewhere as well, showing similarly strong effects. So here's the project I mentioned. I'm not going to have time to go in great detail, but the Ganju Vision Intervention Project was done with CDC control in Ganju province, and there is a myopia boom. So rates of myopia in Asia have not always been historically high. They are growing. So the vast majority of Asian teenagers are short-sighted. And so, working with CDC and also Bureau of Health in Ganju, there was a cluster RCT in 2 counties in Ganju, working as I said, in townships. I won't go into detail, but basically the eye tests were given to children, and they got eyeglasses if they needed them. And what you see here is the baseline balance study. So it's the right-hand side where basically all those big final column got big numbers like 0.8, 0.6. The number there was less than 0.05. It means a significant difference between treatment and control. But the numbers are much bigger than 0.05, so there's no significant difference between treatment and control. So baseline balance worked. Note that of those offered glasses, only around 70% accepted them. So that's common. You don't get full compliance, and you need to deal with that by working working out what's called an intention to treat estimate, as well as a treatment treated estimate. And I'm not going to go into the details here, but basically what we see, and I won't pull it out, but those average test scores, those asterisks on that top line are the research way of showing that's a statistically significant effect. And so when we look at that, has eyeglasses, has an effect on average test scores, has an effect on Chinese test scores, has an effect on maths test scores, has an effect on science test scores. So across the board, you see improvements in test scores. And that's for the full sample. And then you've those compliance samples, this is what's called treated. And below is those that no, I'm going to leave that for now. I was asked by Jimmy to give examples of more RCTs. We are going through time. I won't explain in detail each intervention. This is in the Indian state of Gujarat. Again, this is a 3i funded study done by JPAL. And it was the inspection system for industrial pollutions. And we replaced the existing inspection system with one where inspection was randomly assigned. That's not the random assignment. The random assignment is of the 700 industrial plants in Gujarat, half are randomly assigned to get this new form of inspection, and half forgot the existing system of inspection. And what we saw was dramatic increased accuracy of inspection and dramatic reduction in pollution, output of pollutants as a result of a new inspection system. And again, this got adopted by other states. Zambian hairdressers with an intervention to incentivize female hairdressers to sell female condoms, and they used different reward systems. So one was a financial reward, where you used both a large and small financial reward, and the other was social recognition. So you go along to a ceremony held twice a year. If you sold lots of female condoms, then you get an award given by a local celebrity, someone from a TV soap opera in Zambia or something like that. And what they found was social recognition was far more successful in incentivizing hairdressers to sell the condoms than the financial rewards. When you're doing an RCT, there's lots of opposition to doing RCTs from practitioners. They say it's not possible, we're too busy implementing the program, we can't bother, and so on. One of the responses is, well, we don't need to interfere with everyone getting the program. We just need a subsample in order to do the RCT. So you just pick a selection of those people involved in intervention, not all of them. What's off? Well, treatment design, advantage design that's not used enough as encouragement designs. If you've got anything which is universally available but not universally adopted, there's virtually any social program. It's available, everyone takes part. Health insurance schemes, other micro insurance schemes, various lending schemes. There are lots of government schemes available, not everyone takes part. So you can randomize an intervention to take part in the intervention. So you don't randomize the intervention, you randomize an encouragement to take part of the intervention. That leads to a differential take-up between those who adopt the intervention, those given the encouragement, and those not given the encouragement. And that differential take up allows you to calculate the impact of the intervention itself. So you don't need to randomize the assumption intervention, just randomize the assumption of encouragement allows you to calculate the effect of the intervention itself. In Lanzhou, we're planning in a study, and it sounds very ambitious, of the impact of libraries. And the only way we can, because libraries are already universally available, they are far from universally used. And so an encouragement design is an appropriate design to look at the use of libraries. So we're planning to do an encouragement design to look at the impact of libraries on society. It's there's no such study. It's a very ambitious study we're going to do. You don't need a no treatment control. So in medicine, when a new heart medicine comes up, they don't say, okay, let's take some heart patients and not treat half of them at all and give the other half as new treatment because the other half you don't treat more likely to die. You say the control group will get the existing treatment. Whatever we think is the best existing treatment, the control group will get that. And then the treatment group will get this new treatment. So we're going to see if a new treatment is better than the existing treatment, not better than nothing. So policymakers are really interested in nothing. They don't plan to do nothing. So what are called A-B designs, compare treatment A, treatment B, are very common, are very popular with decision makers. You can also have a factorial design, where you give one arm in the study gets A, another gets B, and the third arm gets A plus B. So you can look at the possible synergies between different parts of the intervention. So you can give agricultural extension, so advice on farming, plus an input subsidy, subsidized fertilizer, subsidized improved seeds, and so on. So you've got one treatment arm just gets advice, one treatment arm just gets the improved, the subsidized seeds and other inputs, and the third treatment arm gets both of those things. The logic of doing that is the farmers need the advice to properly use the improved seeds and inputs. And so doing the two together will have a much bigger impact than doing either one alone. And a factorial design allows you to test the hypothesis. As someone who does systematic reviews, we love factorial designs because they allow us to compare interventions head on head. There are very few of them. Particularly if you're doing what's called a network meta-analysis, you really, really love factorial designs. But there are very few factorial designs in practice. There should be more of them. Non-experimental approaches. So in quasi-experimental approaches, you create a comparison group by statistical means, like statistical matching, which I'll explain in a moment. There are other approaches which are regression-based, which do use untreated observations, but don't formally create a comparison group. So in propensity score matching, what you need, and this is what we did in Bangladesh, you say, we've got here our data on the treatment households. I've got the intervention, you know their outcomes. We need data on untreated households. If you're doing a PSM from scratch, you could just get some data, collect your own data. We're doing next post. So there was an evaluation survey for the project we used for the outcome data for project areas. There was a survey done by a group called Helen Keller International, which is a nationally representative nutritional surveillance survey done every month. So we could match the time of the survey to the time of the survey for the evaluation, which matters because weight for age is very seasonal. And then we could use propensity score matching to get similar households from non-project areas. Similar meaning same sex of household age, same sex of household head, same education for household head, same wealth index, same housing quality, this sort of thing. And so we do what we call a participation equation. This is a probit regression with a dichotomous 0-1 variable on the left-hand side as the regressand, people in the intervention or not. And on the right-hand side are a selection of characteristics we've got from both data sets, like I just mentioned, and we calculate a fitted value from that regression, and that is what's called the propensity score. Here are the values of the propensity score. I'm not going into in detail, and they vary across the core characteristics. We've got the propensity score as a probability of being in the intervention, probably taking part in the intervention. And then that's the participation equation. So here's a participation equation from the Bangladesh study, and you see we include child sex, child age squared. That's non-linear. We can include non-linear terms. Father, female head of household, mother's works. We're living with a daughter-in-law. I'm not going to go into detail here. So all these different household characteristics that are correlates of whether someone takes part in the project or not. And then we establish propensity score, and we establish what we call the region of common support. So that's where propensity scores overlap. So the red bars are the propensity scores for the comparison group. Some of them have very low propensity scores. They're very dissimilar to our project households. We throw away those observations. Some of the project group have very high propensity scores. So they've got there's no non-project house with similar propensity scores. So we throw away those observations. So we work in the region of common support, which is the area in which propensity scores overlap. This idea of region of common support is very important. Any regression-based approach you should only use observations from the region of common support. So you need to do this calculation for any regression approach, like IB, should you still use observations from the region of common support. You match participants with their nearest neighbour. It could be nearest 5, nearest 10. Use what's called caliper matching. Just take those in a certain distance either side in terms of outcome, and you just look at difference in outcomes. Okay, here I've got a propensity score 0.5 in the project. Here's propensity score 0.51 outside the project. What's our difference in outcomes? And you do that every household in the project group, and then you calculate the average different outcomes between treatment and control. That's your impact. And that's how we got this graph, and I'm not going to explain. Here's an example of matching, looking at water supply in Nepal. And so this is using demographic health survey data. And before matching column means what's the percentage of households with access to clean water compared to percentage of households without access to clean water. And you'll see they're very different. And so in the treatment group with clean water, only just under a third live in rural areas, whereas 80% of those without clean water live in rural areas. Nearly half of those with clean water are in the richest quintile, top 20%. There's only 2% of those, 4% of those without clean, no, 2% without clean water are in the richest quintile, and so on. So these two groups are not at all similar. Those with clean water, without clean water, not at all dissimilar. When we see a difference in child diarrhea between the two groups, we cannot attribute that difference to clean water because there's so many differences between these two groups. We do propensity score matching. And here in the final column are the average characteristics of the two groups once we've done propensity score matching. There's roughly a third in rural areas, roughly just over a third in top quintile, 17% of the households have higher education and so on. The two groups now have the same average characteristics. So when we see a difference in child diarrhea, that's now because of access to clean water, because there's no other differences between these two groups. The matching has removed the other differences. That's propensity score matching shown very clearly in this table. Next, design regression discontinuity. This was proposed by the psychologist Donald Campbell. The Campbell collaboration, where I worked after 3IE, was named after Donald Campbell, and he proposed this method to use where there's a threshold rule. So examples of threshold rules are a poverty index. So in India, you have what's called a below poverty line card given to households, and many social programs use the BPL card eligibility. And so households just below the poverty line go in, just above the poverty line don't go in. And so we assume the households just either side of the threshold are very similar. And so we compare their outcomes. Age, so we're looking at the impact of pension schemes or differential benefits, like access to travel passes, whatever. You can use age as a threshold. Exam scores are often used as a threshold, either for entrance into university or college, or to admit people to remedial programs. And so you can use this threshold design again. And here's how it works. There's a correlation between the outcome and whatever threshold criteria you've got, like the poverty index here, and you see an upward sloping measure here. And so those eligible for eligible have a lower level of poverty index, way it's measured. And so when you do the intervention, you get this break. That's why it's called a regression discontinuity. There's a discontinuity in the regression line. And the impact of the intervention is simply that break in the regression line. But this figure's a bit misleading. It comes from this World Bank book, not one I did. It's a bit misleading because it fits the regression line over the whole sample. You don't do that. You fit the regression line of the observation just either side of the break point. So you have to go far enough to get sufficient observations. So use what's called a caliper approach again. See how far you need to go to get sufficient power to get to do the regression, but not so far that you increase the risk of dissimilarity between treatment and control. I'm nearly there. Large and impactful. A lot of people say RCTs are expensive. You've just had a session this morning on survey designs. Surveys are expensive. Okay, large formal quantitative surveys are expensive. So RCTs are expensive because they involve formal surveys. It's always good to have baseline data because you can then do double difference estimates. You can check baseline balance, and keep taking data as long as you can. There are far too few long run studies. So another thing I'm mainly working on at the moment is youth employment programs. And a lot of youth employment programs in developing countries are business skills training. So young people start their own business. And they look at the effect on business after the end of the program or 12 months later that then say, oh, the young person started a business and it's still going. Stylized facts from both developed and developing world, 80% of businesses fail within 5 to 10 years. 80% of business fail within 5 to 10 years. The 80% rule again, most things fail. So most of those businesses are going to fail, but there are no long run studies that show that. And so these young people might enjoy temporary benefit, but it's going to disappear when the business fails. They might end up being in debt instead. In the team, you need sector expertise. I mean, I like being the evaluator. I've been evaluating my whole career because I like learning stuff. So I'll go and work in a new sector I've never worked in before, rural electrification, irrigation, women's groups, and I'll immerse myself in the literature. I just go and read about the topic. Libraries. Now we're working on libraries. So who knew? So now I'm reading library studies. So I like to immerse myself in topics. But normally you need to use sector expertise. When we worked in irrigation, when I was at the World Bank, we had an irrigation engineer in the evaluation group. So I said, Keith, please just give us like Aegis Guide to Irrigation. Just 3 hours, just sit in a room, says all we need to know about irrigation. And I've read several books on irrigation as well. And so I love to immerse myself in a new topic. It's a luxury to have the time to do that, or you need to just spend your own time on that. But the normal way is to use sector expertise. Use statistical experience. Large N approaches are statistical methods. You need to have a basic knowledge, not complicated. RCTs are analytically very simple, but there are more complicated methods like switching regressions, synthetic cohorts, and so on. They're not that difficult. You need a basic understanding of regression. You need to know how to use Stata or R. There are programs in Stata and R that do statistical matching, IB, and so forth. You just type PSM and the variables, and there it is. But you need some expertise, and you need enumerators. And the cornerstone of a good evaluation is good enumerators and a good survey. And so you had the survey session this morning. When I teach survey design, the main thing I emphasize is pilot, 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 and then pilot again. You've got to test your test instruments, and your enumerators need to understand it. People will say, okay, we'll do enumerator training 1 day, 2 days, 2 weeks. 2 weeks for numerator training, because they will not understand the survey instrument. I'm talking about a survey instrument that takes an hour or more in a household survey. And you shouldn't delve much more than an hour, else you get respondent fatigue. But a good survey is well designed, takes an hour, maybe 90 minutes. It's very hard to enumerate properly. You need a lot of training for the enumerators. So, takeaways. You should do a large N impact evaluation if it's conceptually possible. Got large N program, do a large N study. If not, don't do a small N approach just because of time budget constraints if large N is possible. Do randomization if you can, but it has to be ex ante. Time and time again, I've had people come to me and say, oh, I've been asked to do an impact evaluation. Can you help me? Sure. Okay. I want a randomized controlled trial. So I've got a randomized controlled trial. Okay, fine. What stage is the program at? Oh, it's just finishing. Well, we can't do a randomized controlled trial then. No, I've been told it's got to be. Well, please come back and explain you can't do it. Okay, randomization has to be ex ante. If you're doing particularly doing quasi-experimental, non-experimental design, understand the placement rule. Understand the placement or selection rule necessary to understand how to do the appropriate design. And if you've got small N, you've got to use a clear design. So most evaluations, what I call methods 3. I've written blogs on this, are methods 3. And so when they have a method section, they design, as they advise, they describe their data collection. Our method is a sample survey. Our method is focus groups. Our method is case studies. They are not methods. They're methods data collection. They're not evaluation methods. You've got to have an evaluation method to analyze the data. So I say any study design, any research design, empirical research design has 3 parts. One is who you're going to collect the data from. Next is how you're going to collect it, which is sampling. Next is how you're going to collect the data, which are data collection instruments. And the third part is how you're going to analyze those data. And that third part is the evaluation design, process tracing, product analysis, outcome harvesting, don't do that, or whatever you're going to use. Okay, thank you. So I was asked to include all of that, so I have gone for the full hour, but I'm happy to stay here if you are.
Okay, well, thanks very much, Professor Howard. Yes, we I think sprinted through the impact evaluation concept together with you. Our time is up, but I would like to open the floor to a couple of questions because we really would like to use you, and you are the expert in evaluation. So, any question from the audience? Anything also? Yeah, sure.
If no one else. Okay. Hi, Professor Howard. Thank you so much. Fantastic presentation. We could really listen to you for hours, honestly, about more,
I can do it for
especially the
hours, no problem.
results. So my question might be a little technical, but I'm curious about what insights or advice you could give us in terms of ensuring validity of the results of the study. So for instance, external validity tends to be a little murky with development projects when it's hard to find, like you said, a good matches, like with similar characteristics and everything. So I wonder what advice you could give or some challenges you've seen in the work that you've done and how you've sort of overcome.
Okay, thank you. So let's just address both internal validity and external validity. So internal validity is the strength of the design to back up the causal claims you're making about the intervention being evaluated. And for large and impact evaluations, the main threat to internal validity is selection bias. And randomized control trials, generally the best way to deal with selection bias, with some important caveats. And there's a growing feeling and recognition that a well done non-experimental design can be better than a badly done RCT, and I entirely agree with that. And the main threat to internal validity for RCTs is attrition, and particularly differential attrition between the treatment and control groups. And most studies do not report attrition rates. And actually, so one of the people who work with Hugh Waddington is doing a study called participant flow diagrams in economics impact evaluations. And the group at Lanzhou, including Li Ping and Nina, are doing the coding for that. And we're looking at economics RCTs to see if they report participant flow diagrams. Participant flow diagram is what you've assigned 100 to the treatment group, 100 to the control group at baseline. What happens to them? How many are still there at end line? And when you get differential attrition, so you've got higher attrition in the control group and the treatment group, then you've no longer got valid random assignment. Your internal validity is undermined. So that's really important. It's not reported on. So there are threats to internal validity for RCTs and other impact evaluation designs that are under-recognized. Small N impact evaluations have different types of threats to internal validity, from mainly to do around cognitive biases. And if you look at my small N impact evaluation paper from 10 years ago, it's in 2 parts. And the first part is around what are these designs and mainly the theory of change-based approaches. The second part is biases in those approaches. And they mainly come from cognitive biases, confirmation bias, self-importance bias, these sort of things. And we've elaborated on those in recent work we've done to actually do a tool for designing small N impact evaluations. External validity. I think the threats to external validity is can you take these study findings and apply them elsewhere, are overstated. And I'll give a couple of examples. And I've got blogs on this and that. In my forthcoming book from Lanzhou University on evidence-based public policy, buy the book. come to the course, buy the book. So first distinction between generalizability and transferability. So generalizability is a universal claim. Okay, we found this is universally true everywhere. Like the people who did the deworming study in Kenya thought that this study of 6 schools and these 12 worms were universally applicable, or deworming was best by an education. Total nonsense. It's just not true. Okay, and the reviews show that school-based deworming doesn't have these effects anywhere else in the world other than these 3 African countries where these studies were done. But that's generalizability. Transferability is, can I take the studies from this setting and apply them in my setting? I'm not claiming it's universal. I'm just saying, okay, it worked there. Will it work here? Much more modest claim. And so, and a very obvious example of this, which make my point, I think, because people just say, oh, there's no external validity in RCTs. It's just like a knee-jerk reaction to say it. So there was a systematic review published some years ago of the effect of parachutes. So when you're jumping out of a plane, should you wear a parachute? And it was an empty review, so they couldn't find any RCTs of the effect of wearing a parachute when you jump out of a plane. So they said, we can't recommend wearing a parachute because there are no studies. So it was tongue-in-cheek, it wasn't serious. It was like a joke. It was making fun of people who say the only valid evidence comes from RCTs. And so they said, we can't claim that you can do, have to wear parachutes. Then 4 or 5 years ago, probably, someone did an RCT of jumping out of a plane with without parachute. So they had a plane and people jumped out of that plane wearing a parachute and not wearing a parachute. The plane was a small plane on the ground. So people jumped out the plane on the ground, plane like 4 or 5 feet drop, so 1 meter or so, mid-half drop without a parachute, and they found there was no effect in external trauma to people jumping out the plane with or without the parachute. They said, however, we don't think our findings necessarily could be transferred to planes flying at 30,000 feet. Like, hello, yes, obviously, okay? So it may sound stupid, but it's an example where we did this study. We don't think those findings transferred to this other context. And it's very obvious, but actually that can be the case very frequently. So we've done an evidence and gap map on road safety interventions. It's published by Campbell fairly recently. It was done jointly by the team in Delhi, some might be on the call, and IIT Delhi. And in that map, we show that over 90% of the studies come from North America. So 90% of road safety interventions studies come from North America. Over 80% of road traffic injuries and fatalities occur in developing countries. So this is common in health research. We find 80% of the burden of disease in developing countries, 80% of the research is done in developing, is done in developed, that's what I meant. 80% of the burden is in developing countries, 80% of research or more is in developed countries. Does it matter? Yes and no. So some of the risk factors for road accidents and fatality, road accidents are transferable. So driving when you're drunk, driving when it's dark, driving too fast, they're all universal risk factors. So interventions to reduce speeding, to reduce drink driving, to have street lighting, they improve safety around the globe. It's transferable evidence. But the nature of road traffic accidents is different. Who gets hurt in road traffic accidents is different in developing countries. In developed countries, most people injured or killed in road accidents are in the car. They're the driver or their passengers, particularly in the front seat. The people who get killed or injured in developing countries are other road users, pedestrians and cyclists. So most of the studies that have been done are to improve in-car engineering, like airbags and so on, so people in the car don't get injured. Front-end engineering to reduce the effective impact of the vehicle has been underinvested in. So that's not the major cause of fatalities and injuries in developed countries. Also in developing countries, you get vehicle types like tuk-tuks and jeepneys that you don't get in developed countries. So there's no research on safety for those vehicles. So we know from looking at that map and looking at the evidence, some of that's transferable to developing country settings, some of it isn't, and we know why. So I think in my study in Ghana, what I mentioned earlier on basic education, where most of the money has gone into basically rebuilding the education sector. And Africa went in prolonged crisis from the early 80s to the mid 90s, and social sector suffered big time. from underspending. So school education and health systems are in a very poor state of affairs. So what these projects did from the early 80s up to the mid 90s was basically invest in school infrastructure and give textbooks. So over a third of schools got modern classroom blocks compared to straw and flat structures which held up by branches, and the textbook ratio went up from 1 textbook per class to 1 textbook per child. And we looked at the effect of those on learning outcomes and literacy, and it was very substantial. And people said, well, that's not explained, there's no student literacy. I said, in other African countries where you've got this problem, these same findings will apply. Because this underinvestment in education wasn't unique to Ghana, and Ghana was one of the first countries to adopt what's called the social approach to adjustment policies, where they invested in social sectors alongside carrying out economic adjustment. And so you can transfer those findings to Malawi, to Zambia, still to this day to Zimbabwe. In that time I did study, which was 20 years ago. Those arguments transfer. So I think the limits to transferability, externality, are very overstated. And if you understand how the intervention is working and the conditions under which it's working, and what a theory of change-based evaluation does, then you can understand the transferability of those findings. Just to give one other example, the importance of the first 1,000 days in a child's development, which is both nutrition and stimulation, lead to positive cognitive development for the child, which if you don't do it is irreversible again, back to irreversible loss in cognitive development. And so parenting classes, if they succeed in changing parenting behavior, respect nutrition and interacting with the child, stimulating the child, will have long-run benefits for child development outcomes. And I think that's transferable across the world. What you do, so there's an idea called mid-level theory, I can't go into details. What you want to do is transfer fidelity of function, not of form. So the function is you need to change parenting practices to feed the child appropriately, interact with the child to stimulate them. That's the fidelity of function. Fidelity of form, how to deliver those parenting classes, that varies by context. So with the theory of change approach, we're preserving fidelity of function, change in parenting behavior, not fidelity of form. We don't need to do exactly like the parenting classes were done in the US or in the Caribbean where they're first pilots and so on. You adopt it to local context.
Great. Well, thanks very much, Professor Howard. And I know 1 hour is so small for you to mine all your knowledge. So we really appreciate your time and knowledge sharing with us. And now we'll conclude because other speakers also waiting for us for the last session. And thanks very much.
Okay, welcome everybody. So do talk to Jinjin or to Li Ping or Nina about the course we plan in November. And so I hope to see some of you there. Bye-bye.
There they are.
Thank you, Howard.
Bye-bye.
Bye.
Okay.